All right, thank you, Mike. I guess today is the day of the Teresa presentations, back to back. As Mike had said, that we've been working on a TIA project, but the project is one of our implementation projects that is in our larger query center called PRISM. And I'm here to present today on an aspect of implementation, the implementation evaluation that we've done concurrently to the quality improvement program. And so it takes a village to do this type of work. This is both our national team from Prevent. Dr. Bravata is in the middle, and she's the PI of the Prevent program, which is a quality improvement program to improve acute care of TIA. And then scattered across is our implementation core. And we work side by side with the team to collect data prospectively and evaluate the implementation. And I photocropped our remote investigator, Dr. Lauren Penny, who is out of the San Antonio VA and the University of Texas at San Antonio. Okay, so the outline for my presentation today is I'm going to just give you a very brief background on the program of Prevent. I'm sure we'll be hearing more about it from Dr. Bravata in the upcoming months. I'm going to review our implementation evaluation plan and methods, provide our results and conclusions. Okay, so starting with just a brief background of Prevent. It is a stepped wedge design. Over 6 sites are dispersed over 3 waves. So each wave contained 2 VA facilities, and the targeted level is at the facility level. So we had a total of 6 facilities. And as I said, Prevent is a quality improvement program designed to improve the quality of 7 key processes of care. And the primary outcome of that program is a composite quality score called the without fail rate. Concurrently, across the program, we collect and evaluate the implementation aspect of the Prevent program. And prior to this quality improvement program, the team led by Dr. Bravata and a number of us did a national formative evaluation of the current state of TIA care in the VA. And that included 14 VA hospitals scattered across the United States. And we found what were the gaps in care, what were some of the barriers folks were experiencing. And from that data, Prevent was created to overcome those gaps and barriers. And there was 5 components of the quality improvement program: professional education materials to train the providers on the current guideline care. Data was a huge component because there was no data. And other than manually abstracting it yourself, there was no way really for folks to get any feedback on their performance. So an automated way to get performance data was created. With quality improvement support, we strategically placed an external facilitator dedicated to providing support to the groups. There were some clinical specific protocols, like a pharmacy protocol. And then finally, there was a number of electronic health record tools, like a patient identification tool or electronic templated notes that were available to the different teams to locally adapt. Okay, for those of you who are interested in more, our methods paper, which includes the quality improvement and the implementation science evaluation, has just been published in BMC Neurology, if anybody's interested. Okay, along with the quality improvement program, we purposefully planned implementation strategies to promote the uptake of the Prevent program at these 6 sites. And implementation activities is a a cornerstone of the query program. You are required to have implementation strategies. And so we designated these based on, again, the gaps and the barriers that we knew from the formative evaluation. Team activation with sub-strategies around those. The external facilitation, where we are tracking the dose and the timing of that strategy. The creation of a community of practice across these 6 sites where they can have the opportunity to share best practices and learn from each other, and supporting a clinical champion at each site. Often a clinical champion emerges, or in the case if they're not necessarily champions, they're site leads, but we support them with our materials and facilitation. Okay, so next I'm going to go on and to review our methods. This presentation today is focusing on one aspect of the implementation evaluation, and that is to evaluate the user's assessment of the PREVENT program, looking at the team's acceptability of the program, which is satisfaction with the components, as well as their perception is how complex it was and how adaptable it was, and as well as appropriateness, how appropriate was the program to the roles that they currently have. Okay. We use as a guide for our evaluation the consolidated framework for implementation research. In particular, for this analysis, we are targeting the intervention domain, and also in sync with those, that domain are what the field has published implementation outcomes. And I just highlight here from the list, the 2 that I'm focusing on this presentation today: acceptability and appropriateness from Enola Proctor and colleagues. Okay, and this slide just defines those concepts, again, both from Enola Proctor and as well as the CFR framework from the intervention domain. And taking a look at the design, quality, and packaging, but also for appropriateness, the perceived fit with the particular provider's role within their scope of practice. Okay. There's a lot of information on this slide, but this is just a summary of the types of data the implementation core collects side by side the QI team and the different types of data sources that we do. We start off with semi-structured qualitative interviews starting at the baseline, and we carry those out continuously throughout the active implementation period, as well as into sustainability. We do a lot of observations, and I will say you can always find one of us with a notepad and always taking observations of the teams throughout the process. So we begin with a site kickoff, and there's observation components and measurement there, as well as all of the monthly collaborative calls, any aspect of the project, we record observations. We also tend to then debrief after all these events as well, and we record those debriefings. And it's noted patterns, it's noted changes. The debriefs are open, where folks can say anything, and that becomes part of our data as well. There's monthly virtual calls, and again, we're observing while the call is going on, there has been even conversation on the instant messaging across the sites. So we're taking notes of those as well. And then when any team comes back from an on-site visit, there's a post-visit debriefing. And then finally, if that wasn't enough, we came up with what's called a FAST template. It's a rapid, systematic method for capturing key concepts across data sources. So while we're debriefing, if somebody says something that we think is really key, or there's a quote coming out from a collaborative call, we'll say, let's get it into the FAST template. And it's a really quick way to catalog prospectively your observations. I will also just say for all the things that we audio record, we do get them transcribed and then they become our data. Okay, we use in vivo software to work with our qualitative interviews. We code two, we have 2 coders per transcript, and that's just to make sure we are comprehensive in our coding. We have set up a priori code books, but also allow for additional themes to emerge. And the code books were based on the CFR constructs, the Prevent Quality Program, our implementation strategies, and the overall aims that we wish to evaluate. Because we have an N of 6, our analyses are limited to conducting cross-case comparisons. We use matrix analyses, looking at acceptability and appropriateness by sites. We also cross with the specific prevent components. And finally, I'd also describe facility and participant characteristics. Okay, next on to the results. This is just to give you some aspects of the 6 facilities. They are scattered across the geographic region, and the annual TIA patient volume is posted in there. And you see some have been, their volume had decreased down, like site C down to 13 a year, which is about once a month, and that's not that much. Where others maybe have more along the line of 3 or 4 per month. This just gives you a overall summary of the team descriptions and who are the leads. I circle in red. For the majority of the sites, like 5 out of the 6 sites, a neurologist is our team champion or team lead. However, in one of the sites, it was an emergency medicine nurse who led the program. And then another site, a system redesign champion joined the vascular neurologist. So we have a little bit of variety in who leads the programs. The without fail rate on the left this is the baseline fail rate, without fail rate. And again, this is the primary quality outcome. It's a composite quality outcome of the quality prevent program. And so just knowing where they start, the national average at the baseline was 34%. So you have some one below, some are right around the average, and a couple above the average. And that's where the teams are all starting from. Okay. I know there's a lot of information on this slide, but just overall at 6 months, we had 35 interviews across the 6 sites. And then at 12 months, that number went to 28. And these are folks who are the part of the quality improvement team actively involved in the prevent program. And these are just, oops, something happened? Oh, thanks. Thank you. Okay, just to give you just a variety, show you the variety, it's a multidisciplinary team across the 6 sites. Of course, neurologists are available, but also pharmacists had a key role in supporting the teams, as well as some clinical informaticisms, like we called them CACs at our place, as well as system redesign folks. Okay, so also I should mention, I forgot to mention in the data slide, that another form of data we collect is through the automated response system. And these are folks pointing their clickers, but I have been told after pointing my clicker, you do not need to point it. It will just record without the pointing. So that's a false picture there. But the first part of engagement of the team is we led each team with a site kickoff. And at the end of that day-long event, we evaluated their perceptions of the kickoff and what they liked and what was the least helpful. And so across the 6 teams, the most useful elements were reviewing their performance data from the facility on the data hub. This is the first time that they had seen that. And again, we're coming from a field where this data has not been available systematically to the clinicians. They worked on they brainstormed solutions to their gaps at their facility. And number 3, meeting with other staff members from my facility. That was a pleasant surprise that a lot of folks, again, had not had the opportunity to work with each other before, or didn't know. Some of the folks, pharmacists, were saying, I never had the opportunity to meet with neurologists, so this is my first time meeting them. And then at the end of the day, each team had an action plan for where they wanted to go with this program. So they found all of those helpful. The least helpful elements that they rated were the illustrative team dynamics video. And I have to say, that was my idea. And at this point, I think what happened was that they just didn't know what they didn't know. But it was a great example of where it was a model of where they could arrive, and it would help them with the QI program, but we'll go on from there. At that point, they weren't so interested in the handouts or any specific clinical protocols. Okay. And then we also, in this slide, we also asked the teams at the end of 1 year, at the 1 year mark of active implementation, we did ask them to rate their overall satisfaction with the program. And what I did was split out the team lead, the clinical champions rating versus the rest of their team's ratings. And across the board, you can see that the site champions were highly satisfied with the program, and they rated theirs much higher than the rest of their teams. And I put their baseline quality rate to show that it didn't really matter where they started from, that whether you started below the average or above the average, the satisfaction rates were about the same. And we'll go on and show you some other data about the site leads, but the site leads were highly supported. I mean, they turned out to be our biggest consumers of our materials, and they used the most of our strategies, our external facilitator. So they had a lot of support. Okay, so next I'm going to talk about our data from our qualitative interviews to help show some of the themes that we pulled out specifically for acceptability and then appropriateness. So like I just said, the site champions ratings were much higher than the other team members. And these are just 2 quotes to illustrate it. But they felt it was a good experience, the champions would say, and that I would do this again if I had to go back. Yes, I'd still do it, knowing what I know now. And the language is positive, but it's just less enthusiastic. So without really any downside to it, I would say that we improved patient care. So, and I learned a lot. Okay, so that's from one of the supporting team members. We noticed a difference between folks in their ratings between those who had previous QI experience versus none. The folks who've come to this program with prior experience recognized early on, right at the kickoff, that, wow, that this program came with a lot of support materials that you generally don't see, at least I would say in the VA healthcare system. Usually, any initiatives, they're rolled out, they're asked about, they may be mandated, but rarely do you get such ready-made materials that can be locally adapted, and rarely do you get the support from the national team. So those with the QI experience jumped on the opportunity and said, this is great. And including the person who would normally manually extract the data, they recognized getting electronic data was wonderful. Okay, and I bring up the issue of temporality, which in implementation strategies is a key concept about when over the course of time of implementation is maybe the most crucial time for implementation. And we saw some relationships over time with acceptability. And as as the facilities became more accomplished, or as they got more done, their acceptability went up. So for example, we had at least 2 of the 6 sites had very slow starts. The first 6 months was very slow, almost very little progress. A number of reasons why, but and the latter half, they regrouped and they really did well from 6 to 12 months. And you see this relationship emerge about their acceptability. The language is just a lot more enthusiastic. And I'll show you a quote from one of those sites in a second. Likewise, in addition to their acceptability increasing over time, the same thing we can say about the team members' self-efficacy to implement the PREVENT program. They, at the 12-month mark, this is 1 year of active implementation, the QI team members are talking about, their sense of accomplishment that they felt after participating in PREVENT and how they learned so much and that they can go and do other activities. Some talked about spreading what they learned, even this program, to other aspects. Okay. So this is from a site champion at a site. Like I said, they were one who really didn't make much progress in the first 6 months. We were slow to ramp up, but they're really proud at the 12-month mark of what they accomplished. And it was the 2 things that was on their action plan. And they really believe that the care at their facility has changed and that the other clinicians at their site are more aware of the clinical issues and that they are reacting as more along the lines of guideline care. Okay. And then the other concept I want to talk about is appropriateness. And again, this is more of the fit that the clinical provider feels that that the program fit with their scope of practice. And pharmacy team members mentioned that they thought it was highly appropriate that they be involved in this program because what PREVENT was trying to do is well within their scope of practice. There are some of the elements are based on medications, appropriate medications at the right time. And so the pharmacy team members really took ownership of those processes at their sites and really supported the clinical champions. The single nurse champion reported at the end of the active implementation that she really believes a physician champion is needed and that to sustain the progress that they made, a physician champion would get better provider buy-in than her. So that was her observation. And neurology champions who were also serving as their stroke directors at their facility, not all the neurologists served that role, they thought the TIA care was under their scope of expertise, being that it's cerebrovascular care. Okay. So quickly, I just want to talk about some of the individual components of PREVENT. The virtual collaborative calls. This was a big part of PREVENT in that all the 6 sites came together every month. There were different representatives from the sites. And so I would just say, while overall they loved the calls, we did get feedback early on that they did not want to spend time on attendance or roll calls. And they were like, really, please get rid of that. And there was a purpose for having that, and just to get folks to know each other with the names. But we listened, and it was change where the team pictures flashed up, and people can see the names on the calls without having to go through roll call. Okay, the data, team acceptability of the data was, highly rated. Again, they were just comparing IPEC and SAIL are different types, and EPRP are different types of existing data reports in the VA. None have these cerebrovascular metrics, but they were just comparing what the prevent reports were like compared to those. And they trusted the data. That was a big part of, they trusted the data, of course, from one site where their data kept improving, showing improvements. They did say, yes, well, of course I trust the data. External facilitation was well received, and we evolved into monthly office hours to make sure that we can accommodate individual questions and so forth. Interestingly, we also evolved where that the external facilitator would send out monthly emails every time the data hub was updated. And what we heard from folks in the field is that they would use those emails. It was a cue to go check the data hub. Like, okay, my data it's fresh up and we want to see this. So that was a nice cue or nudge to go look at your performance data. The education materials turned out to be a really big hit among the investigators that were, or the clinical neurologists and those who were involved, like had to give grand rounds or had to go and educate the different providers. I would say Dr. Bravada provided professional slide decks and on all aspects of prevent and allowed them to just take it and go and use it. And she got a lot of positive feedback. And at the end, even in sustainability, we've been told by our team members that they still get requests from their facilities to come and give these professional education services because the materials are just so good. Okay. So in conclusion, the Prevent Quality Improvement Program is a highly acceptable and appropriate intervention for multidisciplinary clinical providers in the national VA healthcare system. Acceptability tend to improve over time as teams implemented the program and they experienced success. Acceptability was greater among our site champions, the largest consumers of our materials, compared to their supporting team members. Pharmacists and clinical providers, such as neurologists, thought the prevent was appropriate to their scope of practice. Nursing, not just the nurse champion, but other nurses also said there was less for them to do. So it wasn't targeting nursing as so much. Team participants had suggestions for the team about, again, just some practical suggestions on how to make the program a little bit better. And so we just have a few questions, but I'd be happy to take some questions. Okay, well, thank you very much.